Welcome everyone to the LifeBulb seminar series focused on solid organ transplantation. My name is Karin Hemberger and I'm the president of LifeBulb. I'm also a trained medical scientist, but I've also gone through 3 organ transplants. I'm really happy to be here today with Dr. Husain, representing Columbia University Hospital. I also wanted to extend my gratitude to Veloxis Pharmaceuticals for sponsoring this entire series of seminars that we really hope our patient community will learn a lot from, and also generate, of course, questions that you can send us and continue the discussions on transplantlife.com. So welcome, Dr. Husain. Why don't you just say a few words about what you do and perhaps also what got you into transplant?
As you mentioned, I am a transplant nephrologist at Columbia University Medical Center in New York City. I primarily both work with transplant patients as well as donors for kidney transplants. My clinical care on the recipient side focuses mostly on kidney transplant recipients as well as pancreas transplant recipients. And I also spend a lot of my time doing clinical research in kidney transplant. And to answer your second question, I got into transplant just because I think it's a very exciting field. I think there's kind of very few areas in medicine where the things that we do make a really huge difference in people's lives and quality of life. Transplant is one of those things where you can take someone from a state of really severe organ dysfunction and kind of return them to a fairly healthy, active life, something that's very fulfilling for me.
That is so very true. And I can't believe that it's now a little bit more than a year since I was on dialysis. And then I got my second kidney at Columbia. And now, I'm living incredibly well when it comes to travel and work performance and just happiness. It is very much normal life with a lot of different routines. So
Right.
his focus is going to be about that care management program that is so critical for patients after a transplant. And it involves various different aspects. Of course, the multiple medications that a person needs to be on to prevent the graft from being rejected, but also, of course, the medications that prevent the patient from getting sick or having an infection. And then there are certain complications that patients can experience after many years with the medications or with the graft, such as cancers and cardiovascular disease and so on. So that sounds like a lot of planning. And my question to you is, the transplant center is very tightly involved, of course, in the surgery and in the discharge and that initial period. Could you take us through what the transplant center does and recommends to do first in the first year from discharge, and then what happens after that in general?
Sure, absolutely. And like you said, kind of this will be in general because, of course, different centers and different transplant recipients' experiences will vary a little bit. But I think kind of even on a national, international level, for many patients who follow more standard pathways, things are fairly similar. But I think there's 3 aspects to the management. So one is the management of the allograft itself, or the transplanted organ, we call the allograft. One is the kind of the other kind of care around the management of the function of that transplanted organ. And the third is kind of managing the side effects or anticipated side effects and adverse effects of the treatment that is intended to protect the allograft and maximize the transplanted organ's function. Thinking about those 3 things, kind of each of their importance and kind of focus is different at different times, periods post-transplant. And so I think especially the first 3 months, but typically somewhere around the first 3 years of period, where we're really thinking about how can we make sure we're protecting the organ, because that's at the time when it's going to be the highest risk for things like problems from technical errors, or problems related to early rejection. So kind of it's at its most vulnerable period in that first 3 months and maybe up to the first year or so.
When you say
Yes,
technical errors, is that surgical complications?
exactly. Yes, surgical complications, things as simple as skin infections, or sometimes the transplanted ureter, which is the tube that takes urine from the kidney to the bladder. Because of the way its blood flow is, sometimes it gets a little scarred during the surgery, can cause a impaired urinary flow. Similarly, sometimes the areas where the blood vessels get sewn into the recipient can also get scars. So many kidney transplant recipients might have heard of renal artery stenosis in the transplanted kidney, or narrowing of the artery that brings blood to the kidney. Those kind of things are very kind of much more common in that early post-transplant period, like the first 1 year or less. And so in the sense of those surgical issues, but also in kind of the medical function of the transplanted organ and the risk of rejection, those are all kind of the early focus. So that first year is a time period in which we're focusing on protecting and maximizing the function of the transplanted organ. And so as a result, the care will primarily be driven by the specialist in transplantation, so the transplant center in particular.
Those are nephrologists and surgeons, or are they mostly nephrologists?
I think nephrologists and surgeons, I think at most centers, you'll see that they play a role as a team. In some centers, I think that shifts a little bit as you get, even within that 1 year, as you get further and further out. So, obviously in the first week after transplant, for example, the surgeons are really, really important because the things that are most important to be looking at are direct complications of the fact that you had a major operation. Whereas if you think of a period something like 6 to 9 months after, most of the surgical aspects should be fairly well healed up, and it's primarily medical management of those early risks that takes precedence. So if we start to shift kind of further and further out from transplant, I think then you start to think about those other aspects of kind of optimizing the function of the transplanted organ and avoiding or mitigating consequences of being on lifelong immunosuppression. So if you want to think about things like maximizing function, it's kind of really the same things that we do in normal management of kidney disease. Because remember, that organ is still not going to be 100% the same as a native kidney, what we call a native kidney, or your own kidneys that you were born with. And so it's things like medications to slow the decline of kidney function over time as we age, or things like, for example, the most common reason someone needs a kidney transplant is diabetes affecting the kidney in the United States. So things like medications that protect the diabetes from re-injuring the kidney.
Yep.
Those are one aspect of it. The second is that immunosuppression or the drugs that prevent rejection, those immunosuppressive drugs themselves have a lot of potential side effects related to both risk for infection, because they're obviously suppressing your immune system, but also related to the development of things like cancer, because part of your immune system's normal job is to find and kill cancer cells, especially early cancer cells. And so that involves specialists outside of nephrology. So things like dermatologists who will check you for skin cancer, or your other doctors who do things like age appropriate screening, such as mammography, pap smears, prostate cancer screening, all those kinds of things.
I like how you positioned it. The first year, and especially, of course, so they say the first week is truly surgical.
Yes.
That first year, it becomes more about protecting the graft in that first year because it is still kind of a graft. It's not really part of the person yet. It kind of is ready to settle in. And then starting from year one after surgery or starting into year two, it's about optimizing the function of that kidney that is part of the recipient, and all the things that anyone, a normal person, should do, recipients may be even more focused on because we have a transplanted kidney. So that means being very careful with things that could lead to diabetes, hypertension, kidney disease in general. And then there are certain things that are exacerbated, such as risk for cancer, risk for infection, and because of our drugs, also risk for kidney decline. So that's where you would need to leverage other physicians as well. So that kind of care management plan, then starting really year two, after 1 year, is that run from the transplant center to delegate out to all those different doctors, or is that mostly run by a community nephrologist or even a primary care physician?
Yeah, I think usually a combination of maybe all of those things. I know it's not a perfect answer, just because it takes a lot of different people to manage what ultimately is a very complex set of problems in terms of, you're still a patient with kidney disease who needs kidney disease management, but you're also still a person who has all the other health screening needed for the average person your age, but just kind of with heightened risks. And so I think at a center like ours, for example, you'll still be seeing your transplant nephrologist and your transplant team because part of what they do is still continue to manage the allograft, but you'll also be seeing your non-transplant nephrologist as well as a primary care physician. And I think that can sometimes be very complicated for people who have a transplant because oftentimes when they were getting towards the time of needing a transplant, their own care team shrink a little bit because I think many physicians will defer to the, for if it's a heart transplant patient, the heart failure specialist or liver failure specialist or the transplant nephrologist in the case of kidney disease. So kind of reestablishing care with some of those providers you might not have seen for a long time is somewhat complicating. And then kind of just coordinating between them, because many times people will come to a transplant center, which there are not as many as just general nephrology practices, which might not be the same place where there are other doctors practice. So, for example, many of our patients come from New Jersey or Connecticut and come to New York for specialized care. So coordinating your Columbia nephrologist with your suburban Connecticut primary care doctor, and then maybe your urban Connecticut general nephrologist can sometimes be a little bit tricky. And I appreciate that that's hard for some patients and so that needs to get navigated and you get good at kind of longer and longer you have your transplant for.
So is there kind of a journey map for the patients that they're being given? Here's the plan. You need to go and do these checks. You need all these doctors. And when you've had those checks, someone looks at the totality of the results, or is it really up to the patient to be doing all this?
That's very center dependent. But I think for most centers, I think it's really the latter, which is that the patient ends up being their own point person. Just because I think, to be honest with you, many primary care physicians are kind of uncomfortable with patients who have a very complicated problem like a transplant, especially a transplant that might have had complications in the past. And they also might not be familiar themselves with some of the screening required that's special for a transplant recipient. So I think the centers play a role in saying, make sure that you have to go to a dermatologist once a year now, for example, for skin cancer screening. But many of the patients kind of get a lot of that care locally, especially ones that travel for specialty care to transplant center. So it becomes kind of their prerogative to make sure that based on what their primary care doctor is telling them, based on their general nephrologist, based on their transplant team, that they're kind of integrating all those recommendations and kind of achieving their checklist of all things they have to do, especially because as you get further and further out from transplant, you're seeing your transplant team less and less frequently. And so it's harder for them to serve as a check to make sure you're hitting all of your care milestones that you need to hit.
When you have a patient who's 5 years out and that person has now a skin cancer and may also have breast cancer, do you find out about that from the patient? How does all that link in back to you, if at all?
Yeah, it's a great question. It's again very patient specific, but I think it happens in a couple different possible ways. So I think patients for whom we haven't seen in a while and who may live further away, oftentimes we're hearing from the patients. There, the family members will say, hey, I was just diagnosed with breast cancer. My doctor said this might impact the way that my kidney transplant is managed in terms of immunosuppression, or my doctor has questions about what chemotherapy is safe or what treatment is safe. Can I come back to you and kind of intensify my care at the transplant center again, make it more frequent? Or kind of a savvy clinician from outside the transplant center might also reach out to us with a similar idea saying, hey, we know that now things that might have been on autopilot regarding the transplant probably are no longer on autopilot. So can you start seeing them more frequently again? Because we're going to need to make some change in immunosuppression, or we're going to give you a treatment that might be toxic to this transplanted organ. And they're going to need to make sure they're plugged into that transplanted care before things potentially start going haywire.
Talked about the more long term, and now if we talk about the very short period, hopefully short period after transplantation, during that time period, does the patient have a clear direction of what they should do, meaning returning to the center, taking notes of their biometrics? And are there any tools for them to do so? Or are we still sticking with the kind of paper journal to do so?
I think that mostly that set of tools is center specific, and at our center, I can say it's mostly pen and paper and written down. But I think that every center, whether they refer patients out back to their primary nephrologist at 3 months or 6 months or 1 year, they do so with a very rigorous set of instructions. So I think that for example, for our patients at Columbia, from the day they have their first clinic visit after transplant, they have their entire schedule of visits for the entire first year after transplant. They have a general sense of what their plan will be for the entire first year. They get a list of everyone who they're supposed to be seeing in that first year and a list of instructions of here are the things that might go wrong, here are the things we need calls for, here are the potential scenarios you might face that you do or do not need to call us immediately for. And I think even for centers that refer out more quickly, they do the same thing. I think that's why that process is safe. And I think that center variation is largely based on their comfort level with their referring physicians to make sure they have relationships that those referring physicians also feel comfortable reaching out. Right. So I need to know if I'm going to refer someone out early, that if a certain physician refer the patient to me, that they're going to know how to reach me and when they should reach me if something's not going well. But you're right. I think, things like blood pressure management, medication management, symptom management, most patients are doing it by hand, manually with pen and paper.
Yeah, it could be useful to have something that then also could be collected by the physicians and do some data analysis and generate even some studies from it. Thank you so much. This has been a great interview, and I think we actually touched upon all the different things that I wanted to. Thank you, and again, we're also thanking Veloxis Pharmaceuticals for the opportunity. Thank you.